The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. Welcome back to the Virtual Curbside. This is our monthly episode 4, where we get to ask our speaker all the questions that we've gotten from our episodes for the month so far. And by the way, thanks for all your questions and feedback. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is the week where we get to ask questions, and that's always a good thing. We're very fortunate. Glen Lau has been kind enough to join us again and respond to some questions. Welcome back, Glen.
Glad to be here. Thanks.
Good. I've heard nice things about things you taught us over the last couple of weeks, so thanks so much for your time. Ready to dive into the questions?
Yeah, let's go for it.
Okay. Do you have anything that you should disclose since we last spoke?
Nope, no new disclosures.
All right, we'll work on that for you. We'll try to find conflict. All right. Question number 1. Are there any particular pitfalls in toilet training that may lead to bladder dysfunction later?
Yeah, the main thing, and I think we alluded to this in an earlier discussion, is kind of holding type behaviors. So children who tend to be distracted and put off voiding, that is going to have a higher chance of leading to incontinence episodes, overactive bladder type symptoms, and then can also affect nighttime voiding as well. So that's something to look out for and something we always ask parents about, whether or not they feel like they're having to constantly remind their child to go to the bathroom, or they're doing the quote unquote potty dance and have to rush to the bathroom. So those are things that we look out for.
That's helpful. If that has been an issue, aside from those things, are there any other recommendations you make to parents about how to help kids be more patient and attentive?
So the main thing would be doing more timed or scheduled voiding. And we give notes for school, for instance, to kind of help kids who are in school already be able to go to the bathroom regularly. But we tell parents to work on having a timer or a reminder to have them go every 2 to 3 hours during the day.
Very helpful. I may have said this to you before, but one of the things I tell parents sometimes is one of the big differences between school and prison is in prison, you can empty your bladder whenever you need to.
That's a good point.
All right. Question number 2. What do you recommend for patients with very infrequent nocturnal enuresis? I see patients sometimes who are wet every 3 or 4 weeks. It seems often these are older patients who are even more frustrated because things like sleepovers and camping are even more potentially embarrassing.
Yeah, that can be a really frustrating scenario, particularly if these are older children. The thing that we do in those cases is give them a prescription for kind of on-demand desmopressin or DDAVP, if that's worked in the past, to give them a little confidence when they go on an overnight trip or something like that. It doesn't have to be given every night, but if they need an extra sense of security, then that can be an option.
Are there some people who aren't desmopressin responders?
Yes, there are. And in those, we don't have a whole lot to offer because usually your kids that are going to respond to bedwetting alarms or, oxybutynin are usually having more symptoms than just, those very infrequent episodes. If they're having daytime symptoms, oxybutynin is obviously an option, but those are kind of the things that you can kind of get more on demand. One of the struggles sometimes for me is that if somebody knows that they're going to respond to a medication, it feels more reassuring than to say they can use it situationally. But if they're infrequent, it's kind of tough for them to know whether the medication helped or it was just not their night to be wet. Yeah, and that's true. And I think that, like we had talked about, since it's not something that if it's isolated nocturnal enuresis is something that is a harbinger of bad things to come for their urinary tract, then you can reassure them and then just say that you can use those medications if you have something coming up where you're worried. Okay. Next question. This is a closely related question, and that's about helping an older patient to stop taking vasopressin or desmopressin. This is the question. I have patients
who have done extremely well and are very reluctant to stop the medication, fearing relapse, especially in light of impending going off to college or around here on an LDS mission.
Yeah, and I think that's why we will kind of do like a 6-month course at a time, and then tell them, before they come back on their next well child visit in that case, or come see us, to have a 2-week vacation off of the medication beforehand, before their appointments, so that we can kind of reassess whether or not they need to be on it. I would say it would be rare for someone who's approaching a mission or graduating high school to still be struggling with nighttime wetting. And, in cases where they continue to be, there may be other underlying bladder issues that need to be addressed.
And I think having that reassurance that you take a vacation and then come back and talk, and we can take it from there, is probably reassuring to them as well. It's not like you're cutting off cold. Next question. When do you suspect that psychological or psychosocial factors may be complicating in your ACEs issues?
I think the biggest telltale sign of that would be if they were doing fine for a long period of time before, and the parents actually noticed kind of when there was an onset of the problem. Most children will come in and will hear, oh, they've never been dry at night. And when you have a child where parents say, oh, they were potty trained, they were dry both day and night for a few years, that might be a reason to drill down into other things that may be going on in their life, significant stressors or traumatic events or things like that.
Very helpful. Last question. You mentioned that you mostly use desmopressin and oxybutynin if you treat enuresis pharmacologically. The questioner says, I have had quite a bit of success with imipramine through the years and wonder if there's a reason that I shouldn't use it. Thoughts?
I don't think that there's anything wrong specifically with imipramine. It's not something that is in, as a first line treatment in the guidelines. And I think that's mainly because of the side effect profile being worse than that of desmopressin. But if a patient tolerates it well and they're aware of the side effects to look out for, I don't think that there's a problem with giving it. I just think that we've kind of shied away just because it's a little harder to manage and a little more likely to cause side effects.
Very helpful. Anything else you want to share before we're done for the month?
No, I think, anytime that there are questions of a pediatric urology nature, we do have a physician access line that you can always get a hold of us. And we're happy to answer, specific questions, but no, appreciate the opportunity to talk.
And you guys are always superb about fielding questions. You want to share that number?
Yeah, our clinic number would be 801-662-5555.
Keep dialing 5 till someone answers.
That's right.
All right. That sounds great. Well, Glenn, thank you so much for your time and your expertise this month. Hope we can talk to you again sometime.
Absolutely. Anytime. Thank you.
All right. Thanks again. Everyone who's out there listening, make sure and tell your friends and neighbors and like us and subscribe and do all those things that help spread the word. We'll see you next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.